Welcome back to the Nurse's Study Partner. This is Chronic Kidney Disease, Part 2 Complications and Treatment in 10 in depth scenarios. We'll manage the anemia and bone disease, tackle potassium and acidosis, get the diet right, and move into dialysis, fistula care, and renal protection. Read each case, weigh all four options, pause to choose, then check your reasoning. Let's begin. Question 1. A patient with stage 4 CKD has a persistently low hemoglobin, causing fatigue and breathlessness. Iron studies show he is iron replete with no bleeding. Which treatment is most appropriate for his anemia? Option A, a large one-off blood transfusion for every dip. Option B, a high-dose vitamin C supplement each day. Option C, simply reassure him and give no treatment. Option D, an erythropoiesis stimulating agent plus iron. Pause here and choose your answer. The answer is D, an erythropoiesis stimulating agent plus iron. The anemia of CKD comes from low erythropoietin, so an ESA such as epoetin with iron kept replete is the mainstay, aiming for a target hemoglobin rather than full normalization, which would raise cardiovascular risk. Repeated transfusions, vitamin C, or no treatment are not appropriate. Question 2. A patient with CKD and a high serum phosphate is prescribed a phosphate binder and asks when to take it. Which instruction is correct? Option A, take the phosphate binder with meals and snacks. Option B, take it only on an empty stomach at bedtime. Option C, take it once a week regardless of eating. Option D, take it only when he remembers at any time. Pause here and choose your answer. The answer is A. Take the phosphate binder with meals and snacks. Binders work by trapping dietary phosphate in the gut, so they must be taken with food to be effective. Taking them on an empty stomach, weekly or at random, would not control the phosphate. They go hand in hand with a phosphate-restricted diet. Question 3. A patient with advanced CKD has a low active vitamin D, a low calcium, and a very high parathyroid hormone with early renal bone disease despite reasonable phosphate control. Which treatment most directly addresses this? Option A high phosphate diet to balance the calcium. Option B, stopping all vitamin D permanently for safety. Option C, active vitamin D such as calcitriol plus or minus a calcimimetic. Option D, a large potassium infusion to support the bones. Pause here and choose your answer. The answer is C, active vitamin D such as calcitriol plus or minus a calcimimetic. Because failing kidneys cannot activate vitamin D, giving the active form raises calcium and suppresses the high PTH of secondary hyperparathyroidism, and the calcimimetic can lower PTH further. A high phosphate diet, stopping vitamin D, or a potassium infusion would each make things worse. Question 4. A patient with advanced CKD has a potassium of 6.8. He eats lots of bananas, oranges, and potatoes, and his ECG shows early peaked T waves. Which combination of actions is most appropriate? Option A, encourage him to eat even more potassium-rich fruit. Option B, treat the hyperkalemia and restrict dietary potassium. Option C, give an oral potassium supplement in addition. Option D, ignore it as this level is quite safe in CKD. Pause here and choose your answer. The answer is B, treat the hyperkalemia and restrict dietary potassium. A potassium of 6.8 with ECG changes needs acute treatment. IV calcium to protect the heart, then insulin and glucose or salbutamol to shift it, then removal along with cutting dietary potassium by limiting bananas, oranges, and potatoes. Adding potassium, a supplement, or ignoring it would be dangerous. Question 5. A patient with advanced CKD has a low serum bicarbonate and a mild metabolic acidosis, contributing to fatigue and muscle wasting. Which treatment is most appropriate? Option A, give a strong acid supplement by mouth each day. Option B, encourage deliberate slow breath-holding exercises. Option C, restrict all fluids until the acidosis self-corrects. Option D, oral sodium bicarbonate to correct the acidosis. Pause here and choose your answer. The answer is D, oral sodium bicarbonate. The metabolic acidosis of CKD, seen as a low bicarbonate, is corrected with oral sodium bicarbonate to bring the level toward normal, which can also slow CKD progression and reduce muscle wasting. An acid supplement, breath holding, or fluid restriction would not correct it. Question 6. A dietitian is advising a patient with advanced CKD who has a high phosphate, a tendency to high potassium, and fluid retention. Which dietary plan is most appropriate? Option A, high potassium, high phosphate, and high sodium foods. Option B, unrestricted salt and unlimited fluids each day. Option C, restrict phosphate, potassium, and sodium with moderate protein. Option D, a very high protein intake at every single meal. Pause here and choose your answer. The answer is C, restrict phosphate, potassium, and sodium with moderate protein. The CKD diet limits phosphate, potassium, and sodium and uses moderate, not excessive protein, with fluid guided by the patient's status. High potassium, phosphate, or sodium foods, unrestricted salt and fluids, or a very high protein diet would each worsen the metabolic and fluid problems. Question 7. A patient's CKD has progressed to stage 5, with an eGFR now below 10 and worsening uremic symptoms, fluid overload, and a rising potassium that are hard to control with medicines. Which is now the most appropriate step? Option A, prepare for renal replacement therapy, that is, dialysis. Option B, simply continue the same tablets unchanged for now. Option C, stop all monitoring and discharge him straight home. Option D, give a large high-protein supplement drink each day. Pause here and choose your answer. The answer is A, prepare for renal replacement therapy. Stage 5 CKD with an eGFR below 15 and here below 10, plus uremia, fluid overload, and refractory hyperkalemia signals the need to prepare for dialysis, hemodialysis, or peritoneal or a kidney transplant. Continuing tablets, stopping monitoring, or a protein drink would not address end-stage failure. Question 8. A patient on hemodialysis has an AV fistula in the left arm and a new nurse is about to take routine observations and bloods. Which action is correct regarding the fistula arm? Option A, Use the fistula arm for the blood pressure cuff. Option B. Avoid BP cuffs and venipuncture in the fistula arm. Option C. Take all the blood samples from the fistula directly. Option D. Wrap the arm tightly to help protect the fistula. Pause here and choose your answer. The answer is B. Avoid BP cuffs and venipuncture in the fistula arm. That arm must be protected. No blood pressure cuff, venipuncture or IV, and no tight clothing or watches. The nurse feels for a thrill and listens for a bruit to confirm the fistula is patent. Using it for the cuff, routine bloods, or wrapping it tightly could clot or damage it. Question 9. A patient on peritoneal dialysis at home notices the fluid draining from his abdomen has become cloudy, and he now has abdominal pain and a low-grade fever. Which complication should the nurse suspect? Option A. Peritonitis, infection of the peritoneal cavity. Option B. Simple, harmless, entirely normal dialysis fluid. Option C. A pulled abdominal muscle from lifting. Option D. Ordinary indigestion after a large meal. Pause here and choose your answer. The answer is A. Peritonitis. Cloudy dialysis effluent with abdominal pain and fever in a peritoneal dialysis patient is the classic sign of peritonitis, the most common serious PD complication, and it needs prompt antibiotics, often given into the peritoneum, plus a review of sterile technique. Normal effluent is clear, and a pulled muscle or indigestion would not cloud the fluid. Question 10. A patient with CKD and diabetes has ongoing albuminuria, and the team wants to combine the measures that best protect the kidneys long term. Which combination is most renoprotective? Option A. NSAIDs plus a high salt and high protein daily diet. Option B. Deliberately ignoring the blood pressure and sugar. Option C. An ACE inhibitor or ARB plus an SGLT2 inhibitor. Option D. Stopping all his medicines to rest the tired kidneys. Pause here and choose your answer. The answer is C. An ACE inhibitor or ARB plus an SGLT2 inhibitor. The most renoprotective approach pairs an ACE inhibitor or ARB to cut albuminuria and pressure with an SGLT2 inhibitor, along with tight blood pressure and glucose control and avoiding nephrotoxins. NSAIDs with a high salt, high protein diet, ignoring blood pressure and sugar, or stopping all medicines would each speed up the decline. Let's recap chronic kidney disease part 2. Treat the anemia with an ESA and iron, aiming for a target hemoglobin. Give phosphate binders with meals and use active vitamin D with a calcimimetic if needed for a high PTH. Treat hyperkalemia and restrict dietary potassium. Correct acidosis with oral sodium bicarbonate. The diet restricts phosphate, potassium, and sodium with moderate protein. At stage 5, prepare for dialysis or transplant. Protect the AV fistula. No BP cuff or venipuncture in that arm, and feel for the thrill. Cloudy peritoneal effluent means peritonitis. Treat it promptly. And protect the kidney long term with with an ACE inhibitor or ARB plus an SGLT2 inhibitor, and tight blood pressure and glucose control. Keep going, and remember, we don't pass alone, we pass together.